Thank you all for coming. And I was asked to give a talk titled What You Should Know About Lung Cancer. And um, now it seems like, there we go. Okay. Um, Most talks start with notes and disclaimers, or what is the word? It's where I'm supposed to reveal if I'm accepting money from any companies, which I'm not. Uh, Data and information that I'm going to be sharing with you in this talk is mostly obtained from government websites for epidemiology, scholarly articles. So I'm not I'm not obtaining information from companies, drug companies, or device companies, or anybody like that. And I am not being specifically paid or reimbursed for this talk, even though I'm doing this as part of my role as the chief of thoracic surgery for the medical school and the medical center. So first of all, it's impossible to talk about lung cancer without talking about smoking. And approximately 90% of lung cancers occur in people with a past or current smoking history. Some studies cite as low as 80% of lung cancers, but really is between 80 and 90%. And more people die of lung cancer than breast cancer or prostate cancer. And if you're a woman, you really hear a lot about breast cancer, and if you're a man, you really hear a lot about prostate cancer. And that's because both of those cancers occur with a high level of frequency in men and women, but they're not as lethal as lung cancer. And so um, uh, it's it surprises some people to learn that more women die of lung cancer than of breast cancer by quite a large margin. And cigarette smoking doesn't just cause lung cancer, it causes multiple other kinds of cancers as well, and ends up accounting for a third of all cancer deaths in the United States. And it's a major causative factor in cardiovascular disease and emphysema or COPD. And about 50% of smokers die of a smoking-related illness. It's no joking matter, but I sometimes joke that if it weren't for cigarettes, everybody in medicine would have to be a pediatrician, because there really aren't enough adult health problems that aren't associated with smoking. And smoking also has bystander effects. This is one of my favorite cartoons, lampooning smoking. And if you look closely, you'll notice that the youngster has lost his left eye to presumably his mother's cigarette. So it's not just the mother or the adult in this cartoon who's affected by her own smoking, but it really is affecting a lot of other people around us. And I'll talk about the various ways that that occurs. So first of all, I like to remind people that smoking is very expensive. And every time I give a talk, this talk or a similar talk, I call Liquors 44 in Northampton, and I just ask them how much is a pack of Marlboro Reds. And the other day when I called, so not quite today, it was 2 days ago, it's $14.76. And that was before adding sales tax. So if we add the 6.25% sales tax, that comes to $15.68 for a pack of cigarettes. And over the course of a year for a pack-a-day smoker, that's going to be about $5,700. And over a 30-year span of smoking, that's going to be about over $170,000. And I, for one, can think of a lot of other things to do with that cash, and I'm sure that you can as well. But it's not just, again, how it's affecting the individual smoker and perhaps their household finances. But in terms of affecting all of us, in 2018, according to the CDC data, $240 billion in healthcare spending was related to smoking-related conditions, and also $185 billion in lost productivity from those people with those health problems. And then there's an additional $180 billion in lost productivity due to a premature death in those people. So it's not just that they're missing work because because they're sick, that they're calling in sick that day or are hospitalized, but it's because unfortunately they've passed away earlier than they should have. And these costs boil down to about $20 per pack of cigarettes. So this is tremendously expensive. So each pack of cigarettes, we've now gotten up to $35.68. So smoking is not just expensive in terms of dollars, it's expensive in terms of time. And so compared to never smokers, a non-daily smoker, so somebody who just smokes a few cigarettes a week maybe, they'll have as much as a 5-year shorter life expectancy. And daily smokers have anywhere from around a 10 to a 15-year shorter life expectancy. And a kind of cheeky article came out in the British Medical Journal in the year 2000. They are famous for cheeky articles as well as very, very important articles. But this article calculated that each cigarette subtracts about 11 minutes of life expectancy. And then they boil down here on the on this chart, basically what you could have done in that 11 minutes that you smoked one cigarette, or the 11 minutes that of life lost from that cigarette. So a pack would be 3 hours and 40 minutes, and a carton of 200 cigarettes is 1.5 days of lost life. I always really enjoy looking at graphs of epidemiology through history, and this is data from England and Wales. And what we're seeing on the vertical axis here is the percent of the population that is alive. So we're starting at 100% in the top left corner. And then along the horizontal axis of this graph, we're seeing the person's age in years. And you can see that in 1860, a lot of people died in infancy and early childhood. So we dropped down to almost losing 30% of people at that time. And then in 1910, you'll see the shift in the scale there. Over to 1910, you'll see that fewer people are dying as children, and this is and people are living a little bit longer in adulthood, and that shift is attributed to better hygiene and medical care. And up to 1960, we start to look at that improvement being attributed to vaccinations and penicillin, and that introduction of those medical interventions. And really, nothing has contributed more to the improvements in life expectancy than childhood vaccinations. And so that's a very, very impressive improvement. And then from 1960, in the 1960s, about 40% of the population was a regular daily smoker. And currently, or here in this graph, looking at 2010 rather, the overall average is 20% of the population smoking. And so you can see that reduction in population smoking is further improving life expectancy. Smoking is very addictive, and nicotine in the tobacco is rapidly absorbed and very efficiently absorbed, and binds receptors in the brain with very high affinity, and stimulate the reward center of the brain. And on a milligram per milligram basis, nicotine is 10 times more potent at stimulating the reward center than even heroin. And quitting is very difficult because it's so addicting, and it's not just a chemical addiction, it's a behavioral addiction also. People smoke with their coffee in the morning, or they smoke on a break at work, or they have a drink when they get home from work and they have a cigarette. So smoking becomes tied to a lot of behaviors in a person's day as well. And many people try to quit 5 or more times before they successfully quit smoking. And about 70% of smokers genuinely want to quit, and about half of them try to quit. But unfortunately, a relatively small number of smokers are successful at quitting. This is a graph that is from the, you can see perhaps in very faded print at the bottom, it's from 1971. But this is from the Surgeon General's report on smoking. And this is to show you that more people successfully abstain and quit from an alcohol addiction and a heroin addiction than smoking. So smoking, that graph is right there where heroin and smoking are overlapping. So this is a big deal. And I argue that we're all addicted to smoking, in the sense that we're all addicted to the tax revenue. Federal taxes add $1 and a penny to each pack of cigarettes sold, and that goes to the U.S. Treasury. The Massachusetts state taxes on a per pack basis are $2.51, go to the state general fund. $1 goes to healthcare. And then there's the regular 6.25% sales tax on top of that. And in 2021, Massachusetts collected about $795 million, and only $5 million of those dollars went to smoking prevention programs. So this is $790 million that's going, again, into the state general fund for the most part. So that's your roads and bridges and everything. So we all depend on the tax revenue and are addicted to that. A lot of people smoke marijuana. I am very impressed. I had no idea until I started doing this for a living just how many people do smoke marijuana and smoke marijuana regularly. This is not something that people grow out of after high school and college. Marijuana is often seen as natural. I hear that a lot, and particularly from people who grow their own, but even people who don't grow their own view it as natural. And but it contains many of the same chemicals as traditional tobacco cigarettes, and many people smoke both. So it's very hard to tease out what the contribution of marijuana smoking is to lung cancer development. One study that I saw that I thought was fairly rigorous decided that one marijuana cigarette was equivalent to a pack of traditional cigarettes in terms of risk of developing lung cancer. And when thinking about how this might be, how does one cigarette compare to a pack of 20? I think that part of it is that none of a marijuana cigarette goes to waste. And you'll see up in the corner there's a little picture of a roach clip. I don't know anybody who smokes a traditional cigarette with a roach clip. And people, and it's also the behavior of smoking, of taking a very, very deep breath and holding it. So a lot of that gets very well absorbed, the chemicals in the smoke, but also the particulates in the smoke have more time to settle into the lungs as soot. So for my patients who are daily marijuana users, and I recommend that they shift to edibles, and because their lungs are so sensitive. Electronic cigarettes are not a good alternative. They vaporize a desired solution that comes in a little cartridge, and that solution may or may not contain nicotine or marijuana products, but it's usually flavored or something else to make it desirable. But unfortunately, the solution also contains other chemicals that are harmful to the lungs. And I have read numerous electronic cigarette websites where they talk about all of their ingredients are FDA approved. And what they don't tell you is that they're not FDA approved to vaporize and inhale. They're FDA approved to eat, such as vegetable glycerin. Sure, you can eat that, but it's very harsh on the lungs. The other reason why e-cigarettes are no good is because they're targeted to children. And young people who use e-cigarettes are found to be much more likely to use traditional cigarettes also. So it is a gateway. And I am very fond of reminding people that there are no adult smokers. Adult smokers are all kids who never quit. And the companies know this. Everybody knows this. And I think that we sometimes forget that when we blame people for their own smoking. We don't blame children so much for, we've all done dumb things as kids. But that's why it's targeted at kids because once they get hooked, it's very, very difficult to quit. So that's a problem with e-cigarettes as well. Also, they were originally introduced as a good tool to help smokers quit smoking traditional cigarettes and to be a safe alternative, but it's not very clear that that is turning out to be the case. And there are immediate problems of inflammatory lung problems that are known as vaping-associated pulmonary injury. And long-term consequences and risks of cancer are less clear. The trouble is that cancers take many, many years to develop. And so I think it's going to be at least about 20 years before we start to get a sense of whether e-cigarettes are carcinogenic. There are multiple tools that are available to people to help them to quit. I think that one of the most effective and least talked about sometimes is having an accountability partner. So many things in life are better if you have an accountability partner. So if you have a friend or a family member to quit with, that can be extremely important. And the inverse is also true. If you live with somebody who is also a smoker, the likelihood that you will successfully quit without your partner quitting also is much less. The benefits of smoking cessation it's a long and distinguished list, and it starts nearly immediately within hours. The nicotine and carbon monoxide levels in your blood are down to half, and the oxygen levels in your blood are normal. Within 24 hours, carbon monoxide is eliminated from the body, and by 48 hours, the nicotine is eliminated from the body. And also at 48 hours, a person's sense of taste and smell start to recover and improve. Within a month, people's skin, their complexion starts to look better and brighter, and withdrawal symptoms have stopped. But that's different from craving. I'm told by many of my patients that the craving never stops, unfortunately. Coughing and wheezing decline by 3 to 9 months. And by 5 years, the excess risk of having a heart attack has reduced by half. And by 10 years, the risk of having a heart attack is the same as that of a never smoker. And that is really, really a big deal. And the risk of lung cancer is half of that compared to continued smoking. Unfortunately, it never goes down to that of a never smoker. Radon is the #1 cause of lung cancer in non-smokers, and it's the #2 cause of lung cancer overall. It's attributed 21,000 cases of lung cancer deaths per year are attributed to radon, and radon is a radioactive gas that seeps up from the ground, and it can accumulate in a home. Since it's a home is usually a sealed container, really, that is on the ground. And so something that's very interesting is that buildings next to each other can have very different levels of radon. So you can't decide that, well, this neighborhood is a radon neighborhood or not a radon neighborhood. You really have to check your own basement. So anyone who's bought a house is familiar with this. So here's some the cancer in the United States. This is from the CDC, if I remember correctly, this particular chart. And I just want you to notice that 30% of cancer in women in 2023 in the United States was breast cancer, and only 13% of the cancers in women were lung cancer. And it's very similar numbers in men, about 30% prostate cancer and about 12% lung cancer. But then when we look down at the bottom here, we see when we look at deaths, 21% of deaths in women and 21% of deaths in men from cancer are from lung cancer. And here we can see trends in cancer deaths from 1930 to 2020. The red line is lung cancer, and we can see the increase in lung cancer deaths. And this was in men, and you can see it creeping up here particularly in the 40s, 50s, and 60s. So you may or may not be aware that cigarette companies were taking care of our boys overseas and donating a lot of cigarettes to the troops, and so a lot of young men started smoking in the military during the war, World War II in particular. And women, you can see on the lower graph here, also red for lung cancer. Since they weren't serving in the wars, they weren't getting those rations and starting to smoke with their band of brothers. But women did pick up, and a big part of smoking for women are Virginia Slims, which were specifically targeted to women. Lung cancer survival overall, and so this is all stages, all comers, has been improving very slowly. And so you can see that from 1975 to 1977, very, very deadly. Only 12% of people who were diagnosed with lung cancer were surviving 5 years. And by the 90s, that had only improved to about 15%. And by the 2000s, we're closer to 23 or 25%. Unfortunately, here you can also see some social determinants of health and outcomes, where our Black friends and family members, unfortunately, continue to have less good outcomes. And this is something that is an area of great interest, particularly at Baystate Medical Center, to try to improve. So enter lung cancer screening. For many years, no study could demonstrate any benefit to screening for lung cancer. So we've had mammograms for a really long time. We've been screening with PSA as a blood test for men for prostate cancer. We have colonoscopy for colon cancer. But we really haven't had anything for lung cancer. A lot of negative studies that just did not show a benefit. A lot of chest x-ray studies showed no benefit starting back in the 60s. And then they'd have a chest x-ray and you'd spit in a cup and they'd look and see if they could see any cancer cells in your spit, or, cough up some mucus and spit that in a cup. And then finally, in about 2011, a very landmark study was published demonstrating that screening by CAT scan, by low-dose CAT scan, demonstrated a benefit to smokers. And currently, the guidelines are people age 50 to 80 who have smoked 20 pack years. So pack years is some interesting math that we do. It's just packs per day times number of years, and that is your pack years. So if a person smokes 1 pack a day for 20 years, that's 20 pack years, and 2 packs a day for 10 years is 20 pack years. So it's that's the math. And currently, if you're a current smoker or quit less than 15 years ago, you're also eligible, but that requirement might change. There's some rattling right now that might get dropped, but that hasn't happened yet. So a person has to meet all 3 criteria in order to qualify. And an additional criterion that people don't talk about very much is that a person has to be well enough to benefit from treatment and be able to tolerate treatment. So screening consists of an annual CT scan, and in spite of being recommended and included free in as preventive health to people with health insurance since 2013, less than 6% of eligible people nationally, as a national average, are actually screened. And in Massachusetts, I'm proud to say that we are a state in the union with the best screening rate, but it's still very bad. Only 16% of eligible people are screened. This is a picture of a slice of a CAT scan. And the way that you look at CAT scans is the person is laying on the table in the CAT scanner, and the CAT scanner turns them into a loaf of bread and then cuts them into slices. And when we look at a slice, we're looking up from the soles of the person's feet. So we're looking up from below. So the area on the right side of the screen here is actually the left side of the body. And air is less dense and comes up as black. And other body structures are more dense, and in this exposure level come up as white. And so you can see the lungs here are mostly air, and they have this spider webby kind of texture to them, and those are normal blood vessels. And then you can see in the bottom left of the screen here, I don't know if my cursor shows up for you all, but this blob, this nodule here, that's what a lung tumor looks like on CT scan. I don't want to spend too much time on radiation exposure equivalents, but I do also find it kind of interesting that so a millisievert is the unit of radiation that I'm using in this slide, and is a common unit that is used when talking about exposure from various X-ray studies. And you can see that you get a tiny dose of radiation every day just from being out in the world. And flying in an airliner from Massachusetts to California takes about 5 hours and gives you 0.035 millisieverts of exposure. And that airport scan, where you go in and stick them up and the thingy goes around, you worry, oh my gosh, what's that radiation? Well, that radiation is equivalent to 2 minutes of your flight, which I thought was interesting. A regular chest X-ray is 7 millisieverts, and a low dose CAT scan is only 1.4 millisieverts. So it really is a small fraction of the radiation that a person receives from a regular CT scan. And so I have a question that came up about who chooses a person to participate in the study. I'm going to say that that is usually determined by the primary care. So your primary care physician or nurse practitioner is usually the person who is doing that arithmetic and talking about it. So having quit 15 years ago would preclude lung cancer screening at this time under the current guidelines. So anybody recognize this guy? Would he have benefited from lung cancer screening? He's 56 years old. He's a current smoker and has an 80 pack year history. So he does meet criteria. So yes, he would have benefited. And unfortunately, King George VI, this is Queen Elizabeth's father, he died of complications of lung cancer about 6 months after having his entire left lung removed. How about this guy? This guy's an 83-year-old man. He's got a heavy history of smoking, and he quit 22 years ago. So unfortunately, he would not have qualified for the lung cancer screening program. And both being over the age of 83 and having quit more than 15 years ago. And unfortunately, he died of lung cancer 18 months after his initial diagnosis. So he would have benefited, but unfortunately, he would not have qualified. How about this lady? Lucille Ball, a 77-year-old active smoker with a more than 50 pack year history. Yes, she had an ascending aortic aneurysm, and that would have been identified prior to her fatal aortic dissection. That's actually what killed her. And it would have been found early enough to be repaired electively. So the benefits of lung cancer screening are that the majority of lung cancers that are identified in screening are early stage, and early stage cancers are more likely to be cured. The lung cancer mortality is improved by 20%. And so our loved ones and ourselves, we incur less suffering this way. Also, early lung cancers are less expensive to treat and cure in terms of healthcare costs and lost productivity to society, and also just the emotional burden is less. Other life-threatening conditions can be identified, and so all-cause mortality is improved by almost 7%. And I used Lucille Ball here as an example. But not everything is perfect. There are some detriments of lung cancer screening. There are some false positive studies, so not every nodule that pops up on a scan turns out to be cancer. And so there are risks that are incurred when we're trying to decide if a nodule is cancer or whether it's something that's benign. And there's also a lot of anxiety going through the whole process. There are people who I see who tell me that they're fine until they get their scan and they're waiting for the result. And that can be a very difficult waiting period. And so that's kind of a risk and detriment. So here is a kind of a representation of the stage at diagnosis and 5-year survival. So the top color band here for stage at diagnosis, that's all comers. So those are people who have their lung cancer discovered or diagnosed because they became symptomatic or because they got a CAT scan for other reasons. Again, screening isn't going to have a big impact on that number because overall we're still screening such a small proportion of people who might benefit. And so you can see here that the bulk of people are diagnosed at a later stage. So 44% here of all comers are diagnosed when the cancer has metastasized already. And this is current data. This is from 2022. And you can also see that survival is not as good as stage as one comes to later stage cancers. But in lung cancer screening, we really flip that on its head, and we start seeing that the majority of cancers that are diagnosed are early stage cancers at stage 1, and or cancer stages that are still very treatable and curable at stage 2 and 3. And there's some very recent evidence that 20-year survival in screening identified very small lung cancers can be as high as 80%. And so this is really, it's very, very important for us to continue to try to get people screened and early diagnosis. So I wanted to talk about some advances in treatment. So that's a big advance in diagnosis is lung cancer screening. Advances in diagnosis and management, bronchoscopy. So bronch is Greek for the airways, and oscopy is anytime you do a scope. So bronchoscopy is scoping the airways. And this can be a very important part in diagnosis and staging through doing biopsies. In the last 10 years, there's really been huge advances in endobronchial ultrasound. And that's where on a bronchoscope, on the end of the bronchoscope, an ultrasound device is incorporated in the scope. And it can assist the endoscopist in localizing lymph nodes and tumors to do needle biopsies. And this has been very, very helpful in both diagnosis of the lung cancer as well as staging the lung cancer. So when we're staging lung cancer, we're interested in evaluating whether the lymph nodes in the middle of the chest are potentially involved. And in this cartoon on the side here, you can see that that's the trachea or the main windpipe. And then we're coming down to the right lung airways, and those little green blobs are cartoon lymph nodes. And you can see that the ultrasound is looking at the lymph node and getting a hollow needle to puncture that lymph node and try to get bits of it up into the needle to evaluate to see if there's cancer in that lymph node. So that's been very, very important advance. Navigational bronchoscopy in the last few years has been improving a lot, and the technology in the last, probably 4 or 5 years has really exploded and gotten much better. This is a platform that we are investing in at Baystate, the Galaxy platform, and it's really integrating CAT scan imaging and video game technology with GPS navigation to help us to get a very, very tiny and thin bronchoscope out into the very far airways, and to navigate there and to be able to do biopsies of the nodules from the inside. And so this is really exciting technology that can help us again in trying to decide what is lung cancer, what nodule is lung cancer and not. Surgery, patients come to me all the time and they're just like, I don't want you to cut me wide open and up here and all around. And I try to reassure them that we don't do that very often anymore. Traditionally, thoracotomy, which is a big incision, it can be quite a large incision that goes between the ribs. And we really don't do this very much anymore. Sometimes we still need to do it, but not very often. And so now we do almost all of our operations with minimally invasive approaches, very common. And now instead of doing one large incision, we do a series of small incisions. We've got a camera that goes in and long skinny instruments that helps us to do the operation that we used to need a big incision for. And so a lot of people have heard of arthroscopy. So that's when people put a scope in a joint in your knee or your shoulder. The orthopedic surgeons do that. And laparoscopy is minimally invasive surgery of the abdomen or the belly. And thoracoscopy is the thorax or the chest. So I do almost all of my operations now with the robot. I like to remind people that it's not a thinking robot, it's a tool. And it allows a much finer dexterity of the instruments, and also the optics are much better. I'm just able to see infinitely better with the robot. This cartoon here is showing the robot. Unfortunately, we don't have all the colorful arms on. That's definitely a cartoon, liberal cartoon, but it helps you to see them as distinct from one another. And we dock the robot, and then I, as the surgeon, I scrub out and I sit down at the console that you can see at the bottom here, the surgeon at the console. That's me. And I'm using the little instruments that allow me to open and close my fingers and twist and move around to get the instruments to move inside the body. And I have a bedside assistant or two who's helping with instrument management. Minimally invasive approaches in surgery have a lot of benefits, including less pain for the patient, shorter hospital stays, fewer postoperative complications, which all adds up to getting back to work earlier, and very, very importantly, equivalent cancer outcomes. It's very, very important if a surgeon is doing a minimally invasive operation, that they're doing the same operation with the same quality that they would with an open or large incision operation. We can't skimp. In radiation therapy, in the last 10 or so years, we've had great advances in radiation therapy for lung cancer. This isn't the greatest picture, but it was kind of the best one. It was the one that was showing what I really wanted to show, which is that on the left side of the screen is that big yellow paint stripe is kind of the field of conventional radiation. And it used to be that, radiation had a lot of scatter, and even if the radiation oncologist was treating a small nodule, there would be a kind of a big field that would get treated by the radiation, and a person would have to go back to radiation for 3 weeks, every day for 3 weeks, Monday through Friday, and it would be a very, very big commitment of time, and also damaging quite a bit of bystander lung in the process. And the technology has improved a lot. And at Baystate, we have SBRT, which is called stereotactic body radiotherapy, which is a very, very focused and intense kind of radiation therapy. So you can see that the radiation field is much smaller. And so it's sparing the bystander lung and really just focusing in on the tumor to kill it. And the other nice thing is that it's a much shorter course. It's usually 3 days or 5 days instead of 21 days. So this is great. And the outcomes are excellent. They're not perfect. I thought this was a funny picture. I can't remember what website I stole that from, but I thought it was funny because it kind of looked like Disneyland and a magic wand. And it's not magic, but it's very, very good. And the outcomes are excellent, particularly with small tumors. And the outcomes within 3 years are extremely similar to surgery. And it's surgery is still considered standard of care for early lung cancers, but SBRT is a really excellent choice for people who can't tolerate surgery, either because they don't have enough lung reserve, or their heart is weak, or there are other medical problems that make surgery really not a safe choice. In systemic therapy, there have been some really exciting advances in the last few years. It's the whole playing field has changed so much. Traditional chemotherapy targets really cell duplication or cell replication. So when cells divide, traditional chemotherapy targets that process and prevents that process or kills the cells during the process of dividing. And that's why people receiving traditional chemotherapy can lose their hair, for example, because that's a part of our body where the cells are rapidly dividing to grow the hair on you. Nowadays, tumors are tested for a whole list of genetic mutations and expression of particular proteins to see if those tumors might be sensitive to targeted therapies. And the strength of targeted therapies, as you can imagine, because they're targeted, they're going to have much less effect or no effect on other cells, so that they're going to be more well tolerated and have many fewer side effects. So here's a list. If you watch TV at all, I watch TV very rarely, and when I do, I can't believe all the drugs that I've never heard of that are being advertised directly to regular people. And here they are. Keytruda. I've seen a lot of ads for Keytruda. That's an immune therapy drug. And that is helping to allow a person's immune system to see the cancer cell and participate in killing it. And then there are a bunch of antibodies that are targeting various mutations here that I've added. So you can see this whole list, and this is a partial list But you may have heard of some of these things, and that's what they're doing. And that's it. Any questions?
That was a fantastic presentation, Dr. Ganim. Thank you so much.
Absolutely, my pleasure.
Great facts, man. So much that I didn't know. And it sounds like you've got a lot of therapies for lung cancer as well. So that's really great news.
We do, and I'm really I really think it's going to continue to be very, very important for us to identify people who are who would benefit from lung cancer screening and really getting them screened. And it's unfortunately, clearly very hard for everybody if nationally we're doing not a very good job of it. But I think that as time goes on, we'll get better and better. And
Yeah,
and I look
definitely.
forward to a day when we're screening enough people that we really get to push those survival numbers, push those survival curves over.
Right. The 16% didn't seem like a big enough number, and we were the winners.
No.
Yeah. Oh,
Can you
there's a
ask to be
question.
screened? Yes, you can ask to be screened. It won't be it likely will not be covered by your insurance. I'm not sure what the cash price would be, but that would be something. If you wanted to call our office, I can get you in touch with the phone number.
I know what it is. It's 413
Uh-huh.
794 2222. And
Is it 2222? That's not a number I know.
yeah, no,
What is that number for?
it's that is the make an appointment number for lung cancer screening. It's on our website.
Oh, that's fantastic. That's a great number. But if you are a person who doesn't necessarily meet the criteria, I would be happy to have you call and talk to our nurse coordinator who might be able to give you information about how it works for people outside the criteria. Does that answer your question? And that number, let me give you that number, 413-794-8050.
I'm writing
And
that
maybe
number
I can,
down too.
write that in the, can I write that in the chat? My chat box doesn't open.
Yeah, no, we
Disabled chat?
yes, we did. Yes, sorry. But
Okay.
we
So
can
413, so I'll just say it again, 413-794-8050 for the person who asked the question.
Thank you for that number. That's
Yeah,
awesome.
yeah. No, that's great. Any other questions?
Well, it
Great.
worked out perfectly because we're at time. So,
Oh, perfect. Great. Well, thank you very much, everybody, for coming.
thank you,
And
Dr.
I hope
Ganim.
that was useful. So, there you go.
Wonderful.